Many thanks for the kind introduction. So, I'll be talking about systemic treatments that are available for eczema today, and they comprise tablet options and injection options. And this is a big topic to cover in a short space of time. So, I will very much be providing an overview of this area, and I hope that it's helpful. These are my conflicts of interest. So it feels like a real lift-off moment in eczema. Over the last 10 years, we've been through a period of discovery. We now understand the changes in the immune system that underlie eczema better, and we understand the changes in the skin barrier that underlie eczema better. And all of that has meant that we've had new targets for new drugs. And of course, over the last 6 or 7 years, we've seen the emergence of 6 new tablet and injection therapies into the eczema space and into our clinics. So the aims of this talk really are to provide a brief overview of those tablet and injection options. We will discuss some of the newer options that have come through, as I say, in the last 6 or 7 years, what they are, how they work, how effective they are, and how they compare, at least from the evidence and data that we have at the moment. I'll also give a bit of an overview of a trial that we're running throughout the UK at present called the Beacon trial. So if we start with the basic treatment ladder for eczema, first and foremost, topical treatments, so creams and ointments, tend to be tried first. And where they're not proving effective or are not tolerated or can't be used for any other reason, then second line treatments include light therapy, so that's UV light treatment called phototherapy, or standard systemic tablet treatments. And when I say standard systemics, all I mean by that is these are tablets that we've had for the last 20 or 30 years, and they remain very much our first line go-to treatments for atopic eczema. And these include tablets like methotrexate, which is a once a week tablet or injection treatment, cyclosporin, which is a once or twice a day tablet, azathioprine, which is a once a day tablet, and mycophenolate mofetil, which is a once or twice a day tablet. Newer options or third line treatments include more tablet therapies called Janus kinase inhibitors or JAK inhibitors and injection treatments. And because of the slightly higher cost of those therapies, in the UK, you have to have had or be contraindicated to at least one of the standard systemic treatments before you can receive one of these newer therapies. And actually, in truth, we're lucky now in many senses. Whilst there is still a huge unmet need in eczema, and of course we need more treatments that work in different ways. We are lucky in the sense that we have much more than we've had previously. And the truth is that all of these treatments, so whether it's the standard systemic tablets or the newer ones, they can all work, they can all be effective, and actually they all offer different pros and cons in terms of what you might expect in terms of how fast they work, how well they might work, but also their different side effect profiles. And it's great that we have tablet options and we have injection options that can be anything from daily through to weekly through to actually every 4 weeks now. So there's a lot of flexibility, which means that we've got more ability to try and choose the right treatment for you. So the right treatment for the right patient. So if we delve into the real underlying causes of eczema, it's phenomenally complicated. If we start at the bottom of this slide, the genes that we inherit from our mother and father, so our genetics, are very important in determining our risk of developing eczema. And we know from the genetic work that's been done and from all the other research that's been done that there are two fundamentally important issues in eczema. One is the skin barrier, and the skin barrier not working quite as well as it should do, therefore potentially letting in irritants, allergens, bugs. And number two, a misfiring immune system. And it's how those two things interact, so the skin barrier not working quite as well as it should, and the immune system misfiring, that really drive and propagate eczema. And that's compounded by everything around us, so the environment, whether that be water hardness, whether that be bugs, whether that be any number of other things actually that come in contact with us and are around us. And so it's a very complicated picture. But at the moment, in terms of our systemic treatments, our best way of attacking and improving eczema is to target the immune dysfunction. And we do that using tablets and injections that can in some way modify that overactive immune response that's driving the inflammation, redness, and itching in eczema. I've put this slide in just to show you, firstly, where we are at the moment with newer treatments. So in the center of this, the target board, if you like, we've got the 6 therapies that are now approved and available in the NHS. 3 of them are injections, so that's dupilumab, tralokinumab, and lebrikizumab. 3 of them are tablets, baricitinib, abrocitinib, and upadacitinib. But I also wanted to show you actually how much is happening in the development of newer drugs. So there's a lot more coming. And you can see in late phase trials in the dark blue circle, there are 3 new drugs that are in the next 3 or 4 years likely to come through for the treatment of eczema. And in earlier phase trials, which are 4, 5, or 6 years out from clinical practice, there's a lot more happening. And they include both tablets and injection therapies. Not only are there new treatments coming in terms of tablet and injections, but there are also new creams. And whilst I'm not focusing on that today, I did want to emphasize that there is innovation happening in the world of creams and ointments, which is hugely important for more localized disease. So to give some idea of how the newer treatments work, we have the 3 injections and we have the 3 tablets. So this is a picture of our skin. So this is what you see under the microscope if you take a sample of skin. And you can see the top layer almost looks like a row of bricks, like a brick wall. And the layer underneath that is a light pink color. Now that second layer, that light pink layer, shouldn't really have any cells of the immune system in it, or very few. And what you can see in this image here is that you've got lots of these purple dots in that light pink zone, and they represent white blood cells, so immune cells. And they're sitting there and they're being very pro-inflammatory. They're releasing signals that are causing inflammation in the skin. So here's one of those cells. Now, if we imagine we blow up that cell, and we're looking at it in detail now. So we have the cell and we have the wall of the cell. And on the wall of the cell sit these receptors. And they sit there. And what happens is when an inflammatory signal comes in, it binds to that receptor, which then causes activation of the cell and subsequent inflammation and eczema. And this is a very simple model of what's happening in an extremely complicated immune system. But to give some idea of how these different medicines work, so the injection therapies so in the case of tralokinumab or lebrikizumab, bind directly to one of the key inflammatory signals that cause eczema, called interleukin-13, and stop it being able to bind to that receptor on the cell. Or, in the case of dupilumab, binds directly to the receptor on the cell and stops the inflammatory signal being able to bind to it. Either way, it prevents downstream cell activation and the development of eczema. The way the tablets work is slightly different. So underneath that receptor sitting on the cell wall, there are 2 enzymes called Janus kinases, here in the light blue, JAK, and they are required for the effective downstream activation in the cell. So in a similar way to the biologics, they also prevent the downstream signal, they prevent cell activation, and they prevent the development of eczema. So we've looked at how these treatments work. The question is how effective are they? Well, by and large, we can only really depend on the data that we have. And a lot of the trials with these medicines, either there weren't enough with the ones that we've used for a long time, or the drug has only been compared against a placebo. So we don't have head-to-head data to give a really true understanding of how these drugs compare. But what we can do is get some sense of how they indirectly compare. And this is a really useful website. You can see the address at the bottom. It is updated, and it gives an overview of what you might expect in terms of improvement in itch, quality of life, and overall improvement in the appearance of the rash with different therapies. So, for example, here in the top left box, you can see cyclosporin and methotrexate. The biologic treatments like dupilumab, tralokinumab are on the website. And similarly, you can see the JAK inhibitors. The caveat, or one of many caveats with this data is, as I've mentioned, firstly, it's not a direct head-to-head comparison. Secondly, there is far less data for the standard systemic agents. So that has to be interpreted with a degree of caution. And really importantly, these drugs don't all work at the same rate. So we know that some drugs are much faster acting than others. So cyclosporin and JAK inhibitors are very rapid acting drugs. We know, on the other hand, that methotrexate and biologic treatments can take a little bit longer to reach absolute maximum effect. So the cartoon in the bottom right really is just to depict that if you were to move the finish line, so whereas all these results that are in front of us here represent the data at 8 to 16 weeks on treatment, if you were to move that finish line and say move it to 24 weeks, you may very well see a very different readout. And so every medicine needs to be interpreted in the context of its character and the way that it's expected to perform. So how do we choose which treatment we actually use in clinical practice? And more importantly, how do you choose which treatment is most appropriate for you? Well, there are a number of things we think about. So with dupilumab, for example, we know that it can help in treating other conditions in what we call the atopic group, which comprises asthma, eczema, hay fever, and nasal polyps. But it has side effects, and they can include conjunctivitis or irritation of the front of the eye in about a third of people, facial rashes in around 1 in 20 people, and joint pains in around 1 in 20 people. So these are some of the things that we and you might take into account when thinking about a treatment. The other injections, tralokinumab and lebrikizumab, work in a very similar way to dupilumab. Tralokinumab may take a little bit longer to hit maximum effect compared to dupilumab and lebrikizumab. The side effects are probably very similar. We don't know if the rates of those side effects are exactly the same. And so we need more data in real-world usage of these medicines to learn if there's any lesser risk of irritation of the eyes, for example. And JAK inhibitors, they are not as targeted and as specific in the mechanism as the injection treatments, but they are probably a little more targeted than the conventional drugs like methotrexate and cyclosporin. So they do have a very different side effect profile. They're tablets, they work very fast. They can help other conditions such as autoimmune problems with hair loss, vitiligo, or inflammatory bowel disease, which may be strong reasons to use these over other potential treatments. But they have side effects including infections, particularly cold sore virus and shingles, stomach upset. Occasionally they can cause a bit of acne, headaches, and blood test changes, and some rarer side effects. So they have a slightly different side effect profile to the injection treatments. And so it's all about balancing the pros and cons of these therapies in any one individual and scenario. So we have an idea about how they all work. We know about the mechanism through which they work, and we understand their side effect profiles. But what we don't really understand well enough right now is how they directly compare. And that's where Beacon, the Beacon trial comes in. And I mentioned at the beginning, I would very briefly just touch on this at the end. So the cartoon on the left here is the Caucasus race from Alice in Wonderland, which I love that story. But this animation is actually quite appropriate in terms of all of the trials that have been run with new treatments in eczema, because to some extent they're all running their own race. So each trial is usually comparing a new drug against a placebo rather than a drug that we've always used. They may be having a readout of data at a different time point. It might be 12 weeks in one trial, 16 weeks in another, 24 weeks in another. And the population of patients going into the trials is never exactly the same, which means that it's very hard to understand quite where any one drug lies in the overall landscape of medicines. So the aim of Beacon is to actually understand how do the drugs compare head to head, giving them time to perform at their best. How do the new drugs compare to the ones that we've used for longer time periods? And should we use the newer drugs earlier in our treatment pathway? How well do these drugs work, and how well are they tolerated in more real-world populations? And Beacon is a very pragmatic trial mirroring standard care in the NHS. And importantly, which of these medicines represent good value for our NHS? So the key question is, what is the most effective, tolerable, and cost-effective systemic treatment for more severe eczema in adults? The key people involved are adults with more severe eczema who require systemic treatment. And the treatments that are involved in the trial are cyclosporin, methotrexate, dupilumab, and abrocitinib. So in other words, two of our very standard treatments and often first-line treatments, and two of the more novel agents. And the trial started a year ago. We've got 24 sites planned around the UK. You can see on the map on the right there that we are making good progress. So all the green dots are now open. The amber ones are imminently about to open, and there should be a reasonable geographic spread for participation. And what does the trial involve? Well, very simply, it's based on standard NHS practice. Patients are randomly assigned to one of the four treatments. Apologies, that should say four treatments. There is no placebo, so patients will always get an active therapy, and participants will know which medicine they are on. There are around 6 visits across 1 year, plus some safety visits depending on which medicine people are allocated to. Where appropriate and where relevant to the medication, participants will be able to increase the dose of the drug at 3 months, just as we would in standard practice. So that's the case, for example, for cyclosporin and methotrexate. And at 6 months, if the medicine hasn't been as effective as you or we would like, there is a switch option, which again mirrors NHS practice as much as possible. Creams and ointments can be used throughout the trial. So the fascinating thing in the world of trials is that they're evolving all the time. They're becoming more efficient, they're becoming more clever. And we've seen, for example, here, these are two big trials that have been run over recent times, and they're called platform trials because unlike traditional trials where you start with 2 or 3 medicines, you run the trial and the trial stops. With platform trials, you start the trial, but if new drugs are developed in the time the trial is running, you can then add them into the trial. So it's really efficient and effective. And recovery, that you may all remember, was a big part of the news during COVID here in the UK. Recovery was a great exemplar of a platform trial. So as treatments were coming through and treatments were thought about that might work in the context of COVID, they were added to the recovery trial. So Beacon has been set up in the same way. So Beacon will enable us to add in new drugs as they emerge in the future. And hopefully with the results and the head-to-head data, we will start to be able to put together the pieces of the jigsaw a bit more accurately. We will have more direct head-to-head data to give you a truer readout of what to expect on the different medicines, the pros and cons of them, and which one might suit you the best. So to summarize, there are multiple new systemic treatments to treat more severe eczema. They include injections and tablet treatments. We need to know how those newer treatments compare against the ones that we've always used and still routinely use on a level playing field to inform our best practice. And we hope that the Beacon trial will provide that information as well as providing ongoing information as new drugs emerge in this field. So if you're interested in learning more about the trial, please do go onto the website and have a read. You can self-refer to the Beacon trial, so you can enter your details and we will contact you and put you in touch with the nearest site if you're interested. I hope that was helpful and thank you for listening.